Ubaldo sir.
Sir, good evening, sir.
Yeah, hi. So all the very best. So you've got a beautiful transmission. It looks great.
Thank you, sir.
ரொம்ப சூப்பரா இருக்குங்க சார். ரொம்ப அப்படி brilliant-ஆ அப்படியே your stage everything looks fantastic and your shirt is also so colorful. You are also looking very colorful. அப்படி ரஜினி ஸ்டைல்ல ஒரு இது ஸ்கார்ஃப் எல்லாம் போட்டு பேட்ட படம் பார்த்த மாதிரி இருக்கு இப்போ உங்களை பார்க்கறதுக்கு.
Sir, how is the video? அதான் சொல்றேன். Video okay, sir?
ரொம்ப சூப்பரா இருக்குங்க சார். Video, audio, everything is super. Fantastic.
Thank you, sir.
So my best wishes for the whole function, sir. I'm going to be a mutant spectator, just going to watch. But phenomenal, fantastic, வாழ்த்துக்கள்.
Thank you, sir.
Yes, பாலா கேக்குதுங்களா? பால் பால் நான் பேசுறது கேக்குதாப்பா?
நல்லா கேக்குது சார்.
பால்
கேக்குது கேக்குது. நம்ம ஆடியோ கேக்குது. ஹலோ
பாலா பாலா
ஓகே.
பாலா நான் பேசுறது தெரியுதா? கேக்குதா?
சார் கேக்குது. நம்ம பேசுறது அவர் கேட்குற மாதிரி தெரியல. சார் நாங்க பேசுறது கேட்கலையா?
Bala, good evening.
Hi BGM கேக்குதா?
Yeah, நல்லா கேக்குது. கிளியரா கேக்குது பாலா.
கேக்குதா? கேக்குதா?
எஸ் எஸ்.
நான் பேசுறது கேக்குதா?
சார் நீங்க பேசுறது கேக்குது. ஹலோ
BGM குட் ஈவினிங் கேக்குதா?
எஸ் எஸ் எஸ்.
கேக்குதா?
நல்லா கேக்குது. எஸ்.
கேக்குதா? நான் பேசுறது நீ ஹலோ சொல்லுங்க, நீங்க சொல்லுங்க.
ஹலோ பாலா, ஹாய். ஹலோ.
ஒன்றும் கேட்கலையே. வால் அப்படியா? அப்பயே நீங்க பேசு என்ன கேட்கல. ஸ்பீக்கர் என் ஃபேஸ் அங்க வருதாடா? எனக்கு நீங்க தெரியுறீங்க, ஆனா பேசுறதுக்கு வரலையே. ஸ்பீக்கர் மேல கொஸ்டின் ஆன்சர், மியூட், ஸ்டாப் வீடியோ, ஷேர் ஸ்கிரீனு, பார்ட்டிசிபென்ட்ஸ் மோர். ஓகே ரைட் நான் பார்க்குறேன் ரைட். லைனில் ஸ்பீக்கர் வரலாம். கீழே வந்துச்சு.
Good evening. Dr. Prasad, Mohan Prasad.
ஆஃப் பண்ணி போட சொன்னாங்க. அந்த ஸ்பீக்கர் கழுது இதுல மாட்டவே இல்லை நானு காட்டு
இதாங்க இதானா
அது அது
Hello. Hello. Hello, Prasad. Are you hearing? Check.
லூசுப்பையா இதே போது நல்லா தான் இருக்குது சூப்பரா இருக்குன்றாங்க.
பளிச்சுன்னு இருக்கு.
ஆமா
சூப்பர்.
இந்த மாதிரி
Mohan Prasad. Prasad.
Well, sir. Hello, sir.
Good evening, lah.
Oh yes, very well, very well. Sir, good evening, sir.
Good evening. How are you?
Sir, நல்லா இருக்கேங்க சார். நீங்க பேசுறது ரொம்ப கிளியரா கேக்குது சார். இன்னைக்கு காலையில தான் உங்களை தினத்தந்தியில பார்த்தோம். இப்ப நேர்லயே பார்க்கக்கூடிய வாய்ப்பு எங்களுக்கு. சார் வலிக்கலையா சார்? உங்க கை வலி இல்லையா?
Bala, good evening. Dr. Bala.
Sir, good evening. Good evening, sir. Good evening.
Good evening.
சார் கேக்குதா சார் இப்ப?
Yes sir, yes sir.
Well, okay. கேக்குதா?
கேக்குது. நாங்க பேசுறது?
நல்லா கேக்குதுப்பா.
ஓகே 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 சார்.
இத மாட்டிக்காம பேசினா எங்க முடிச்சிட்டு கேட்க போகுது எனக்கு. BGM, good evening.
பாலா நீங்க எதுலயும் மாட்டிக்க மாட்டீங்க பாலா.
God's grace.
Hi Bala. Hi Mohan Prasad.
கொரோனா கொக்கு எதுவுமே உங்களை தொட முடியாது.
ஏன்னா வெளியே வர்றதில்லை.
Hello.
Raghuram sir.
Bala. How are you?
Sir, good evening. Good evening.
Good evening. Good evening.
Ali, good evening. Prem, good evening.
Sir, Raghuram sir, Ali, Prem, all good evening sir. Happy New Year, happy Pongal belated.
BGM கேக்குதா?
Yes, yes Bala, I can hear you.
Okay. Clear sound ஜாஸ்தியா இருக்கா?
நல்லா loud and clear. Loud and clear.
Okay, right.
Dr. Bala, you're looking smart in t-shirt. T-shirt தான். இல்ல t-shirt தான்.
அலிட்ட கூட ரொம்ப நாள் ஆச்சு.
Sir, you are in work from home style, sir?
Work from home style தான் அது. நல்லா இருக்கியா பாய்?
Fine, sir.
Prem, how are you?
நல்லா இருக்கேன் சார்.
பிரேம் ஹேர் கட் உங்க வீட்லயே பண்ணதா இல்ல நீங்க எங்கயாவது பார்லர் போனீங்களா?
யாரு?
பிரேம் 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 ஹேர் கட் வீட்லயேவா இல்ல பார்லர்லயான்னு கேட்டு.
டாக்டர் பாலா போட்டோ பாத்தீங்களா? அபார்ட்மெண்ட் போட்டோ பாத்தீங்களா? போன்ல வாட்ஸ்அப்
கேக்குது சொல்லுங்க.
You have sent photograph of the apartment, trust apartment. WhatsApp.
அது உபால் முதல்ல அனுப்பிச்சிருக்கான். செட்டிங் தானே சொல்றீங்க?
Send it to Mohan Prasad also.
செட்டிங் தானே.
Sorry.
சொல்றாரு பாலா. அத வந்து வாட்ஸ்அப்ல அனுப்ப சொல்றாரு.
அவருக்கு அனுப்பிச்சு மோகன் பிரசாத்.
உபால் அனுப்பிச்சிருக்காருப்பா முதல்ல எனக்கு.
Rama sir, good evening and congratulations. All the very best, sir. Robert, sir, we can see you and welcome.
Hello. Good
Hi.
evening, Dr. Robert Haas. Vanakkam. How are you?
I'm doing
Dr. Haas,
very
how are
well.
you?
Can you hear me?
Yeah, I'm
Yes,
hearing you.
yes,
I'm
yes, sir.
hearing you.
Good evening. Good morning, Dr. Bala here, sir. Good morning. How are
It's
you,
so
sir?
good to see you all. Oh, fantastic. Fantastic. How is everybody?
Fine, sir.
All well. Nice to see
Fantastic.
you. You're looking good. You're looking good, Dr. Haas.
Thank you. I'm happy to be with you. I'm sorry I can't be there in person.
But today being virtual is being like very close, and we feel really real seeing you in person. But where is your junior, your trainee guy, Shyam?
He's probably still sleeping. I'm sure he will be joining soon. Can I just do just a little bit of logistics here? So with this Zoom, when it's time for me to do my presentation, I go to the upper right-hand corner to look at view. No. Okay. So is everybody safe? How is the COVID doing in India?
Yeah, it is. Numbers are down. Comparatively, it is now reduced now. We have started the vaccine. We have started the vaccine program, launched the vaccine program yesterday, and I have had the vaccine yesterday. Are you hearing?
That India was going to be the prototypical vaccination country.
Sir, yes, please tell me. We are not able to hear you now. Can you repeat?
I was just saying that I read in the newspapers that people thought that India was going to be the prototypical vaccination country.
Yes, yes.
Hope so.
We have started yesterday.
Fantastic, fantastic.
Ramki, good evening.
Good evening. Oh, always there to handle the technology.
Super.
Bala, good morning.
Hi, Shyam. Good morning. Vanakkam.
Bala.
Hello, Shyam. Good morning.
Good morning, huh? Good morning,
Now
Mohan.
you're having your coffee. Hi.
Yeah. We don't get filter coffee, but it's okay. What can you do?
I have my Starbucks.
I know.
Yeah, that's nice. Good.
Shyam, when are you coming to India?
I just came from India.
Oh wow, we missed you.
My whole mission is to hide from you, Mohan.
Oh, God, that's so sad. So sad.
No, I was in. We went to Coimbatore and then went to Chennai. Got my kids some citizenship cards, OCA cards, everything, and then
wow,
it's raining in Coimbatore, Mohan.
Oh, you were there for a week?
Yeah, and I was there for 2 weeks.
2 weeks, wow. I could have given a tinkle to you. So
it was raining, it was raining all the time. Huh?
So next time, give a call.
Someone, are you going to sing the MGR song for the launch today?
Wow, if you order, I'll do that. Bala has to tolerate it, and Rob won't understand the song.
That doesn't matter. Yeah. MGR is like a cult. He's God. These days, God, okay? It doesn't matter.
Today is his birthday. Today is birth anniversary, 104th year.
Really?
Birth anniversary today.
I didn't know that.
Oh yeah. So that will be befitting, of course.
Okay.
So good to see everybody.
So that venue must be a very historical house, right, Bala?
No, it's not a historical house. This is the guest house of Mr. Mutaya.
Oh, it's guest house.
Where they put the guests now.
Okay. It's a fertilizer factory. It's called Speak.
Yes, yes.
Yeah.
No, it's not a Speak guest house. It is a personal guest house.
Okay. It's one of those guest houses where only you have access. If we go to those guest houses, the dogs will start chasing us.
Sorry, can you repeat, Sham? I'm not able to hear you. Sham?
It's dogs will start chasing us. You can hear. Can you hear me? Audios.
Cheyenne.
Yes, sir.
I think that on the Zoom call that I had yesterday, if there is sort of technical problems, we turned off our video, and that sort of opened up some lines. So if we have technical difficulty, that may be one thing that we can do.
Wow, why did it happen, Ra? Usually it should not happen, right?
Really?
Yeah, you go to India.
You know, there were 30 people on the EMF, or maybe 50, and then some people, they didn't get their slides, and so they asked us to start turning off our video.
Dr. Krishnan, good morning, sir. It's so nice to see you.
Sir, good evening, sir. Krishnan, sir. And KR, sir, good evening.
Colonel sir, good evening. Raghuram sir, good evening.
Good evening. How can I miss that stentorian voice?
Cheyenne.
Yes, sir.
Krishnan looks the same as the last time I saw him.
Dr. Krishnan?
Yep.
Yeah, he still has more hair in his head, Rob. That is he still has more hair in his head.
Yes, Sham, I can't hear you. Tell me.
I told Rob that you still, Dr. Krishnan, you still have more hair than him.
No, I have more midline than anywhere else. That's the problem now. Now I got to heave before I put the belt in the buckle. Next time, Raghuram says, best thing is to come with a dhoti kurta.
Dhoti and kurta.
How are you, Sham? You tell me all about you.
Nothing much, Dr. Krishnan. We are now in a new health system. We left years, and then we are now started in a new health system. So it's a slow start. Hopefully, we are going to recruit another doctor, and this time, in addition to endoscopy, we have to set up gastroenterology in the system. It's a chain of about 8 or 9 hospitals. So the first year is going to be very slow for us. So 21 is going to be just setting things together, and then next year things will gather pace. But otherwise, everybody is good. Uday is good. G is good. Rob is here. We are all the same. Fortunately, we were lucky enough to stay together. Usually, most groups don't stay together for this long. So I think we are very lucky to be here for more than 10 years together. Okay.
Yes, Dr. Bala. Dr. Bala. Are you hearing us?
கேர்பு சார் பேசுங்க.
No, are you be ready? We are about to start now. All set.
சார் அங்கிருந்து பேசுறது வாய்ஸ் கம்மியா இருக்கு சார். இதே ஷாம் பேசுறதுக்கு எனக்கு கிளாரிட்டி பெட்டர். ஷாம் ஹலோ சொல்லுங்க.
ஹலோ.
நல்லா இருக்கேன்.
Hello. Are you hearing me now?
Yeah, but feeble, sir. Anna.
Is it better now?
Now better.
Is it better?
Yeah, now better.
Yeah.
Okay, fine.
Yes. Yes.
Yeah, we are all set now.
Okay.
601, I think.
2 more minutes, Kerb, sir.
2 more minutes.
Subal, 2 more minutes, Subal.
Oh, okay, sir. Okay, sir. When you say start, we'll start.
Yeah. Subal, Matan sir kamipa. Hello, Chalila. Sir, good evening, sir.
Good evening, Bala.
Sir, good evening. Dr. Bala here, sir.
Good evening, Dr. Bala. How are you?
I am fine, sir. Thanks for making it, sir.
Good to see you again. Oh, all of us are on screen. Okay.
Subal, voice feeble இருக்கு Subal பேசுறது.
எல்லாம் மாஸ்க்னால சார் மேபி. How is my voice?
உங்க வாய்ஸ் கிளியரா இருக்கு. Probably you have to be இது போடியம் மைக் இல்லையில.
Check.
Subal.
சார் சொல்லுங்க சார்.
It's time up 6 மணி ஆயிடுச்சு வர கிராஸ் ஆயிடுச்சு.
ஆடியோ ஓகேவா சார்?
நீ பேசுற கேக்குதுப்பா.
Right, sir. So good evening, everyone. I welcome all the senior members and friends. It is a great moment for all of us, and it is a dream 1 year ago when myself and Epan had a chat in the last year inaugural meeting that why don't we start a journal for the trust, and it is a reality today. And I welcome Dr. Balasubramanian to give the welcome address.
Thanks, Subal. Good evening, ladies and gentlemen. On behalf of the trustees of the Tamil Nadu Gastroenterology Trust and the editorial board of Gastroenterology, Hepatology, Endoscopy Practice Journal, I welcome you all for this unique launch meeting of the journal in the printed form. We have launched this through the web long time back, but we are looking out for an auspicious day, and today happened to be the auspicious day, so we are starting it. We are extremely happy and thankful to Dr. Colonel Krishnan sir and Dr. V.A. Mathan sir for accepting our invitation to release the journal. And I request Dr. K.R. Palaniswamy to hand over the thing when your turn comes, sir, to Dr. Colonel Krishnan. and our editor-chief, Dr. Ramakrishna, to hand over this journal to Professor V.A. Martin for him to relax. Our special thanks to our friends from US, Dr. Robert Haas, and our always friendly Tamilian from US, Dr. Shyam Varadarajulu, for kind enough to give a lecture today on this eve. Welcome you all once again, and thank you very much, sir. Yes, Subal.
Thank you, sir. And now the release of the journal. I request our two wise men in the crowd, Professor Mathan and Colonel Krishnan. Our publisher will give, Palaniswamy will give to Dr. Krishnan sir, and BSR will give to Mathan sir. Both of them will release simultaneously. From Professor Krishnan and Mathan sir.
Yeah. Back.
Maybe back now.
This is the Indian custom. There are few words, everybody has to speak. Driving down, I was wondering what I should speak if in case Ubal trusts me the charge. Dream is something recommended by two leading people in our country. One is a great scientist. Vivekananda says, you will dream well if you have a restful sleep, Brahma. And you will achieve your aim if you have a restless sleep. Is that clear? And that's what Rama has been doing, is going to bed with a dream and waking up to catch that dream at the aim. So I think he's been the backbone of this. And of course, you can't give enough tribute to the duo, Palaniswamy and friend Bala, also known to some people as Bala Subramaniam. We all know him only as Bala. It's a Himalayan Herculean task, and the administrative aspect of it, they've done a tremendously very good job. And last of all, Ubal, I don't know, there's only one non-Tamilian here, so I can still use that word. He's the one guy who is not perturbed for anything at no time. Uchi meedu vaanidinde vizhinam, achamallai. He'll be just sitting there, that's all. But somehow he gets things done. So this quartet of people have done a remarkable job, and I've gone through the journal. The decor is excellent. The presentation is very good. The print is highly satisfactory. But at my age, I would like the font, Rama, like better than what it is here, because I have to go very close to my light. It's a wonderful opportunity. Thank you very much for allowing me to participate in this, and may God bless you all.
Well, I anticipated I might be asked to say a few words, so I was thinking what I should say when I came here. I, for one, historically have always resisted the publication of journals. Resisted them because I believe only high-quality articles should be published. Many years ago, when the Indian Society of Gastroenterology decided to publish a journal, they asked me to be the editor. And I said, I will be the editor if the editorial board has full rights to reject any article they feel is not up to the mark. And they said, no, 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 sir, we have to encourage people. So I said, my job is not to encourage people, but my job is to get excellence. But over the years, I'm proud to say that my colleagues in the Indian Society of Gastroenterology have really brought out an excellent journal, and I look forward to it coming regularly and I read it carefully. And I'm sure that this journal, whose first edition, I got a copy of it and I looked at it, is very interesting, will continue to maintain the high standards, because I have seen that the gastroenterologists of Tamil Nadu do maintain a high standard. And we have a large number of postgraduate students, and their supervisors will see to it that they produce work of high standard, which is published regularly. Thank you for inviting me to release this journal. It's a pleasure to be with all of you.
Just add one word about when Martha was talking about the earlier attempt, the banks of our Indian University of Gastroenterology journal, it was Hyderabad. The only 3 units in the country were producing papers. That was All India Institute, PG, Chandigarh, and Vellore. And all the 3 of them said, we will give it to some. In those days, it was recognized by the Index Medicus. It's still over there, is it? Still? Okay. And some of us, I was appreciating President Vice President, and we requested at least one portion of it, change the title, change the wording, change the word, something. You know, it's almost plagiarizing, but still, let's get the journal until it is recognized. No way. Finally, it was put to vote. And these guys won by 21. At the time, you know, and I lost. I couldn't make it. Subsequently, when I think, Rama, you must get somebody to write about Professor Antia. But for him, the Indian Society of Gastroenterology journal would not have come. His entire house was office, full of papers. Philip what? Bombay. Philip, Subhash Naik, and Shobana. There are 3 people who used to go there, sit there. Subhash has taken me a couple of times over there. That old man just keep on giving us tea and biscuits. This will reach that level.
Thank you, sir. A few words from Professor Raghuram.
I don't have that rich experience as Mathan and Karna Krishnan. Mathan was my examiner in DM, and I used to be afraid of talking in front of him, literally. Though he was very lenient, he was not as strict as he was talking. He's very lenient examiner, but he was strict in academic work. And Indian Journal of Gastroenterology has come up to a level. This is only for Tamil Nadu Gastroenterology Trust. This journal is from Tamil Nadu Gastroenterology Trust, mainly for our people. And I hope the articles will come in future from the other parts of the country as well, because journal getup is excellent. One of the excellent journals I have seen coming from the India now. First edition is excellent. I hope they maintain this quality subsequently. Congratulations, Rama and Ubal, for the excellent job, and Palaniswamy, Bala.
I request Dr. B.S. Ramakrishna, his editor's address.
Good evening, everybody. So it's a great opportunity to launch this journal. My teacher and mentor, Professor Mathan, is here. He says, he said, you heard him say that he felt there are too many journals around. We actually hold a kind of contrarian view. In the sense that I think people everywhere need to get into a culture of publishing. And that really is what this journal was about, to try and foster an academic spirit amongst the gastroenterologists in Tamil Nadu. And this would take us back to the physician-scientist concept, which exists widely in the US. And so this, I think, I've been taught by physician scientists, so I'm proud to be one myself. And we really want to encourage this. And I hope that everyone here in the Tamil Nadu gastroenterology world and outside will send in articles for publication here. We already have a couple of people from outside the country who've sent in articles. And there's even been an offer to buy the journal.
I request Professor Mohammed Ali to say a few words.
Good evening to everybody. I think it's a great and proud occasion for the society and the trust for having launched a journal of international repute. And I must congratulate Ubal for his great work in initiating this job. And we have a great editor in Ramakrishna, and he's an international man, and we know of the work he can do, the quality work. And of course, the backbone for all this, Professor Palanisamy as well as Dr. Bala, they have been behind them to get this initiated. So I must congratulate them, and I hope this work continues and we bring out papers of international repute. Thank you.
I request Professor Ratnasamy to speak.
தை பிறந்தால் வழி பிறக்கும். மகிழ்ச்சி அளிக்கிறது. I'm very happy. People used to say publish and perish. I would like to say publish and flourish. This journal gives an opportunity to young gastroenterologists publish their work, and I am very happy to be part of this function on which the journal is being released, the print version. I congratulate Dr. Ramakrishna, Dr. Bala, Dr. Palanisamy, and the whole team is involved in this, and wish all the best. Thank you.
I request Dr. Palanisamy to say a few words and proceed with the speaking.
Good evening. In fact, we are honored from the trust. I'm happy to bring out this journal and release it today as a print version. And I would like to brief, and also I would like to thank Professor Robert Haas and the Dr. Sham. When I asked Sham about this, requested him to give a lecture, immediately accepted and communicated to Robert Haas, and he also readily accepted. I would like to thank both of them. This is a Sunday early morning there, and they're up and ready to give a lecture for us. Thank you. And I would just briefly like to say a few words about the trust, because we've been saying trust. The trust, we formed the trust in the year 2003. That is following we held an annual conference of gastroenterology in 2003. With the savings from the conference, we started the trust and just moved forward. Basically, from the trust, we had activities like several academic activities, national, international. Also, we have had several public awareness programs, and also the camps, free camps, village levels. And these are the basic activity. We have been very active from the beginning. Regarding the journal, I think, in fact, when the journal, this was discussed by Ubal initially with the other colleagues, we were very happy. And when he contacted us that we can bring out from the trust, we were very happy and have accepted the same. And generally, and it's very difficult to publish in the journals. Most of the journals are research oriented. This journal, of course, as you all aware, it's a practice oriented journal. And here, See, we are all, we are sort of, we hesitate to sort of send us the work for the publication. To just, I would like to quote a few examples. Even in private practice, you can do research. I would like to quote Dr. Amara Purakar from Bombay. He was in private practice, but he did really a very good work. But only other thing is you have to collect, document your data. When you have a documentation of the data, then you look back, collect, and then sort of, then you can really bring it out as a case report or publish. That's what he has done. He has, in fact, he has had several publications, and he has published both in national level. I think you should time for it. You should allocate time. What we probably lack is we don't specifically allot time for the research. Amongst our busy practice, we should spend some time. And one more thing, most of the journals, they don't accept or they don't encourage case reports. So maybe I think GHEP, Dr. I will request Dr. Ramakrishna to encourage publication of case reports. So with this few words, I would probably wish the journal a great future. Thank you very much. I think we are ready to go for the lecture. The first lecture, I would like to request Professor Robert Haas to start his lecture now.
So first of all, it's an incredible honor for me to be a part of this. Having worked and known Shyam for as long as I have, it's been ingrained in me the importance of research, and so this is, I think, just a really great honor for me to be a part of this. I'm so disappointed I can't be there in person, and because I'm looking out over all you wonderful people and good friends and so forth, and it's difficult to do the Zoom because it's a little bit impersonal. But again, my congratulations to the entire group. I really think that this is an important initiative, and I offer my support now and ongoing in any way that I can. I had a few slides that I wanted to share with you, but when Bala, when I click on my share screen, my Zoom says that the host disabled the participant screen sharing. Is this a function that you can release for me, or? It's saying that I can't share my slides.
I think they're trying from this side. That is already done. I think you can try sharing.
Okay, fantastic. Okay, so it's I had this problem before, and I don't know how to solve it.
Rob, I can pass you. I can use. You want me to share your slides? I can do that.
Yeah, can you do that?
Yeah.
Is yours showing it?
I think I can pull up your slides. Give me a second. Yeah, I do have them here, right there, and we can go. Yeah, let's.
Yes.
Roll. Yeah.
Okay. Thank you very much, V. So I'm gonna have to talk to G to figure out what my problem is. So again, my sincere congratulations to everyone involved in this, and I wish you the best. And again, I want to express my my commitment to help in any way that you feel possible. What I would like to do is talk a little bit about, go back, V, to talk a little bit about the future of endoscopy. I know that this is only part of the charge of the journal, but it's the area that I am obviously most involved with, and then how the future of endoscopy should impact the journal. So next slide, V. So if you look at endoscopy, up until now, there are several phases of reaching a diagnosis and then treatment. And the first is actually to stratify risk, to visualize, to get a tissue diagnosis, to stratify risk. The second phase is a screening and surveillance. So you identify an at-risk population, and then you do surveillance and screening. And then once you detect disease early, then this provides an endoscopic, an opportunity, I should say, for an endoscopic treatment. And up until now, these first two functions have been served by doing endoscopy. But I would propose to you that in the future, and particularly I think in the Indian population, this will be done not only non-endoscopic blood tests, smears, etc., but it will also be done by non-physicians, not by standard physician endoscopists. On the other hand, as you look to the future, Tricia, again, thank you, B. The early detection of disease and endoscopic treatment will, in fact, require an advanced endoscopist. So next slide, B. So if you look at healthcare reform, and I believe that this serves a purpose in India as well as in the United States. If you look at diagnostic endoscopy, just the procedure of looking and doing endoscopy on somebody with dyspepsia, that actually is a costly endeavor. However, if you look at therapeutic endoscopy, particularly if therapeutic endoscopy replaces a surgical procedure, then you're looking at money saved. And I think that this is important. Next slide, V. So these are, this is the triangle of the goals of healthcare systems. I think that this serves in the United States, but serves in India as well. And it's this interaction between lowering cost, increasing access, and then improving outcomes. And the way we manipulate our system is to maximize each of these issues. Push the forward button, V. For diagnostic endoscopy, I believe in India that this will be disrupted. Probably not because of lower cost, because costs in India are really very, very inexpensive, at least compared to the world. But it does have great potential to increase access. There is great potential to increase access. If you look at the number of gastroenterologists in India, it is substantially lower than it is per population in the United States. And so I believe that the future of endoscopy is creating a situation where we can increase access. Next slide, B. So also there is this issue of non-physician performance of endoscopy. And this is a summary, it's a meta-analysis done in quite a number of papers that have looked at flexible sigmoidoscopy, colonoscopy, and EGD, looking at the outcomes and the diagnosis when it's performed by a nurse practitioner or a nurse or a physician assistant versus being performed by a physician. Next slide, B. And this meta-analysis showed very clearly that if you look at outcomes, all measures of quality for flexible sigmoidoscopy, colonoscopy, and EGD, that there really is no difference between a physician doing the procedure and a non-physician physician extender. So I believe that this will be a part of the future of endoscopy, at least from a diagnostic standpoint. Also, although the cost has been prohibitive so far, I still believe very strongly that visualization of the GI tract without requiring sedation and without requiring an endoscope really holds incredible promise in the future. If we can reduce the cost of these capsule endoscopes, if we can modify them and improve them, I think that this method has great promise for being a method of doing diagnostic endoscopy, which increases access to the population and is a good resource to develop. Next slide, V. And this is a study from India that just points out it's a comparison between standard endoscopy, so endoscopy performed in a standard way, to a magnetically controlled capsule. And if you press the slide, V, you can see down here that the accuracy of the capsule when compared to the standard, which was EGD, the accuracy was about 93%. So if we can get ways to control the capsule so that we can get a thorough examination, it looks like there is promise that this technology could be quite equivalent to a standard endoscope. And you can see that in the digital age, I could very easily see if these capsules were inexpensive, that they can be administered by any kind of physician extender. Obviously, once the images are generated, they're digital, so they can be sent to a center where they can be interpreted by a qualified individual, and then the results of that can be sent back to the source, and a treatment can be initiated. So I see this as a real future in terms of diagnostic endoscopy. Next slide, V. So this is another example. This is primarily used for Barrett's esophagus. It's a cytosponge. But it's a method of gathering cytology without doing endoscopy. And again, this kind of non-invasive tissue acquisition that could be performed by a nurse or an allied personnel, I think, again, is areas that need to be explored in terms of diagnostic endoscopy as a way to lower costs, but more importantly, to increase access, which I think is the key to GI healthcare in India. Next slide, V. So this is now moving a little bit forward. I've gone from diagnostic endoscopy and express my views on where I think that is going and the impact that it can have on a large population like India. But I now want to go to therapeutic endoscopy, which I think is sort of diametrically opposite. That is that while diagnostic endoscopy, I think, will be disrupted and should be disrupted, I think therapeutic endoscopy needs to be refined and resources put into it to increase it in terms of training, et cetera. This is a study out of the Amsterdam with Jacques Bergman's group, but it's a multimodality eradication of Barrett's. It's a European multi-center trial. They took patients with Barrett's esophagus with high-grade dysplasia or early cancer. They applied both EMR for visible lesions, followed by RFA, radiofrequency ablation for the smooth Barrett's. And if you can just press the button, V, you can see that per protocol, so if you followed this protocol, again, taking patients with high-grade dysplasia or early cancer, you apply this protocol, you actually got complete eradication of neoplasia in 98% of patients and a complete eradication of intestinal metaplasia and 93%. So, you know, I'm getting a little bit onward in age, but I can still distinctly remember that a patient with multifocal high-grade dysplasia at the beginning of my career, those patients went to esophagectomy. And now we've come to a point where we can apply therapeutic endoscopy and we can get a 98% complete eradication of neoplasia. So complete eradication of neoplasia in 98% of patients in a procedure that essentially is an outpatient procedure compared to what we know is the postoperative difficulties of esophagectomy. So the potential for therapeutic endoscopy, I think, is really remarkable. Next slide, V. And then if you look at a cost analysis of this, again, this is important for the Indian population as well. This is a cost analysis of EMR versus surgery for large laterally spreading polyps. And if you can press the button V, you can see here the cost difference per patient in managing somebody surgically with large colon polyps versus EMR, at least in US dollars, which I'm sure is remarkable at the cost of healthcare in the United States compared to India, but the cost differential was about $7,600. So again, appreciating that the costs of surgery, hospitalization, et cetera, is lower in India, still you got an outpatient procedure that has potential for substantially lowering costs. And I would also argue that access to therapeutic endoscopy should be much, much greater than it is for a formal operating room. Next slide, V. So this is where the cascade of events that I see for therapeutic endoscopy. I think there'll be refinement for standard therapeutic endoscopy that we've talked about sort of all along in terms of stenting, et cetera, endoluminal therapies, hemostasis, et cetera, on to submucosal surgery, and then on to even exploring the chest and abdominal cavity from inside the GI tract, are all represent potential for therapeutic endoscopy going forward. Next slide, V. So my last slides are just my thoughts on your efforts to start a new journal. And I think the first thing that I would say is really create a very, very concrete vision for your journal. You cannot be a New England Journal of Medicine. That's already been established and has a history. So what are you? What do you want to do? How do you want to serve the population? Who do you want reading this? So what is your vision? And when you create that vision, really stick with it. Don't be swayed by the times, et cetera. Stick with your vision. The other thing that is, I think, maybe most important is that when you start a project like this, there's lots of enthusiasm because there hasn't been very much work go into it. You've had lots of talks and enthusiasm, and people say that they're in for this and so forth. It's very easy to conjure up the energy to put on the first meeting or to start a journal or to start something. But the key is sustainability. Where will we be in 10 years? If I come and visit in 10 years' time, will this be a vibrant, expanding, relevant journal? Or will it be a situation where just the last person standing is sort of trying to carry on the journal and there is no interest at all? So I would say early on, look very, very carefully at sustainability. What is your niche? You can't be everything to everybody. So what is your niche? Really, where do you want to fit this journal into the myriad of journals that are already out there? Create a product that people want to be part of. This involves, I think, getting young people involved. It certainly involves looking at the entire array of mediums that we have now for disseminating information. And there should be minimal politics. This should be a situation where the workers are and the visionaries are really creating this. This should not be mired down in politics. Engage and encourage the young people and the young talented people. They really are going to be the sustainers of this. Many of you have the connections, the connections with pharmaceuticals and money and advertising, and there's a lot of things that you can do to make this journal sustainable and relevant. But you've really got to engage the young people and the talented people to sustain this journal and so forth. V will talk about this, I'm sure, but really the journal should serve as a nidus to increase research. I think that I would hope that young investigators or investigators in Tamil Nadu will see that they do have a viable, relevant, widely read a place, if you will, to put the research. So the research doesn't go into the ethos and disappear. And so I think the journal should be a nidus to increase research. And have a good and viable business plan. Okay, you can't do this without a good business plan. Can you push the forward, V? And this I didn't consult with V, and I'm not sure how he's going to respond to this. But in my very lengthy career, I've never engaged with anybody who, number one, is so dedicated to research, but number two is so savvy and energetic in terms of publication. I went through a time when he applied to be the editor of GIE. I looked at the extent of his vision for the journal, and had he gotten that position, I think the journal would be up there with JAMA and New England Journal of Medicine and Gastroenterology and all those journals in terms of their impact factor. So please involve Shyam as you plan and so forth. So the final slide, V, is where you should go in terms of an editorial board, at least as it pertains to endoscopic, the endoscopic section. I would encourage submission of research that advances diagnostic endoscopy in India. I think innovative ideas that will expand GI diagnoses from an endoscopic or quasi-endoscopic perspective should be carefully reviewed. They should be, recommendations should be made for strengthening the paper, but then it should be published. Encourage submission of innovative technologies that improve endoscopy in India. So encourage those kind of technologies. And then finally, when it pertains to endoscopy, really videos are the basis for our practice. So you need to have an ability to publish videos that go along with the journal articles. There probably, I think, should be a video section. V, I'm sure will go into this, but video is a format that is almost indispensable with regards to endoscopy. So next slide, V. That concludes my my presentation. As V indicated, we have a new home in Orlando. In about a year's time, we will have a state-of-the-art endoscopy unit. And we look forward to the time when we can project procedures from our unit to India. And we certainly look forward to times when we can welcome all of you to our unit for a visit to join us in Orlando. So with that, I'll conclude. And V, thanks for rescuing my slide presentation. And to all of you, thank you so much for allowing me and giving me the privilege to be a part of this journal inauguration. Thank you.
Thank you, Professor Rob Haas, for the excellent lecture on future of endoscopy and principles in starting a new journal. I forgot to introduce Professor Robert Haas before Robert Haas started the lecture. Dr. Rob Haas is one of the pioneers in the field of endoscopic ultrasound and also the notes and the third space endoscopy. And he's the teacher for Dr. Shyam Varadarajulu. Of course, Dr. Rob Haas is familiar to most of our Indian audience, but however, younger generation may not know him. That's the reason I thought I'll say a few words about Rob Haas. And I have probably a few questions, interactions among us. You want to ask any questions or anything to Rob Haas? Any interactions, anybody? Oh, yes, sir.
I'm old enough to be forgetful, Professor Haas, but I thought the first gastroscopy was done by a non-medical person. Am I right? Irshowitz or some Polish sounding name. Is that right?
So the very first flexible endoscopy, is that what you are talking about?
Yes. Well, it was about 15.5 circumference millimeters. And it was somewhere near New Jersey, if I remember correct. Oboski, something. No, I had met him once. I mean, you met him too. Yeah.
Wow.
Just a thought. The word that impressed me most among the many points you made is some of the technicians, what do you call the sister practitioners in your country? There are also some of them can do very well, and that's very impressive. I don't think doctors will let go of that in present situation. But it's a need for shared diagnostic endoscopy. Why should a qualified doctor waste his time?
So we shall move on to the next lecture by Dr. Shyam Varadarajulu.
Yes. Can you hear me?
Sorry?
Yes.
Shyam Varadarajulu is well known to all of us and among the Indian the audience. And Dr. Shyam Varadarajulu is known to us and a good friend of ours. And first I invited him for 2003 when we held this annual conference of gastroenterology in Chennai. And from then, of course, he just at that time, people are wondering. We asked, many of them asked me who this he looks like a medical student. From then, because I've been observing, his growth is phenomenal. He's one of the leaders in the field of endosonography. And in fact, both Rob Haas and Dr. Shyam Varadarajulu, they're responsible for the development and improvement of the endosonography in our country. So without wasting much time, I would request Dr. Shyam Varadarajulu to start his lecture on the publication and professional development.
Okay. Thank you, Dr. Palaniswamy, and it's such a pleasure to be here this morning. I was just in Chennai last week, so happy Pongal to everyone. It's a little belated. This talk is very close to me, and I will start sharing my screen in a minute. I've been asked today to talk about publications and professional development. So for those of you who don't know, so Rob, Dr. Mathen, who's sitting in the stage, you won't know him. He's from Christian Medical College, Vellore, with Dr. Ramakrishna, and he's also the teacher of Shajan Peter. So that is how important he is. I have not seen him, maybe I've seen him many years back. So he's Peter's teacher. And I don't think you can have a more qualified person than Dr. Ramakrishna to run the journal. When I was a medical student, not a medical student, when I was a resident, I think I saw his manuscript on diarrhea and the treatment in the New England Journal of Medicine as an original article, and it was written Christian Medical College. And those were the days that we thought such fantastic research can originate from India. So he's eminently qualified to run this journal. And It is such a pleasure to be here. I was not sure if Dr. Krishnan will be here for the launch of the journal, but this is probably his most favorite image. This is the Andal temple in Srivilliputtur, where we both have origins. And this is a picture that only Dr. Krishnan will recognize. Was my grandfather's 119th birthday last week when I was in Chennai. And I don't think the new generation will recognize anybody else in this image. And it just came out in a local newspaper last week when I was there. So Ubal asked me today to select a topic, and I thought the most correct topic will be to talk about professional advancement and its relevance to publications. In endoscopy and gastroenterology in general, professional advancement is not easy. It is not a fair game. I think it's because there's stiff competition. Although there are fewer gastroenterologists in a place like Chennai, it is saturated. We have got more than 120 gastroenterologists, and there is competition. And when it comes to career growth in endoscopy, it is usually controlled by a tight network of select few. These are people who do research together, publish together, who are connected tightly with the endoscopy societies, and who can further their growth. And sometimes it can be difficult to break into this network. Therefore, access to new technologies and research opportunities and growth in the profession can be limited to people unless they are part of this network. But it's very important early on to say, how can you set yourself apart from others? So if you look at me, I was a foreign medical graduate from Chennai, India. When I applied for an advanced fellowship in Charleston, there were only 4 programs in the United States that had advanced fellowships, and there were only 2 positions a year. So early on, it was very obvious to me. Jim Freston, who used to be the president of the American GI Association, told me the only way you can set yourself different from all other graduates in the United States is publications. And the way you publish is you have to do more than the other person if you want to do it the correct way. It is not about knowing somebody and having someone make phone calls for you, but you need to stand on your own merit. And in publications, there are different reasons to publish. In academic centers, you are not respected if you don't publish. It's very simple. You will be just relegated to be a clinician to do some procedures in the clinics. So you have to be a physician scientist, because unless you publish X number of papers and original articles in peer-reviewed journals, you are not going to be promoted from an instructor to an assistant professor and so on. In private practice, there's no obligation. You don't need to do anything. And the only reason to do it in private practices, it has to come from your heart and from your souls. And you have to be really, really motivated in private practice to publish. And what is professional advancement? You can have all these laurels and everything in an academic institution, and unfortunately, you will not make any money out of it. Or you can work as much as you want, and then you can have your backs broken. So you can be very financially successful, but you will not feel a sense of satisfaction towards the end of your career. So it is very important to have a balance of both, if possible, where you have a good academic career and also be financially well compensated at the same time. Then I think professional career will appear satisfying for a majority of practitioners. But in general, the reason for publishing is not just to publish a little bit of your experience, but you want to move medicine to the next higher level. You want to see where medicine is in the particular area that you're addressing, and you want to know how you can elevate the field to the next higher level. If you can do that over the next 10 to 20 years, your findings will be taken to change minds and policies. For example, pancreatic pseudosis. They were all treated by surgical gastrostomy or percutaneous tube placements. Today, endoscopic drainage is the norm, and the societies have moved to advance this into their guidelines to say this is the first line management for all accessible collections. To get that, it took about 15 to 20 years, and your work is laying the groundwork or the substrate to move to the next higher level. Personally, this is the best way for you to be accepted as a referee or a leader by the peers in your field, because you've shared your experience, which has now become the standard of care locally, regionally, nationally, and internationally. And this is why publications is important. And what does it take to publish? I really think it takes a lot of effort and a lot of commitment. I don't think you can get up one fine morning and say, well, I'm going to start publishing. I don't think it really doesn't work that way. It requires a lot of discipline. It requires lots of effort. It takes lots of commitment. And if this is perceived as a painful process, and if you are going to roll your eyes before you write your manuscript, I think it is, at least you're not made for it. For me, publications, when I want to write a manuscript, it's the best time of the day. When my day goes horribly wrong, there are complications, politics in the hospital, meetings, and things don't go well. When you have a cup of coffee and you sit, when you sit in the evening in front of your computer, that is the best thing that can happen. It's like going into a state of meditation where you forget everything else and you start publishing. And your ideas can happen anytime. And to be honest with you, the best ideas to me come in the shower. You just sit there in the morning and then you close your eyes and then you come with something. And then I can't usually get it out of my mind, and you think about it. And another time to do it is first thing in the morning. You go to your office at 5:30 or 5:45. You got about an hour and a half or two. And then you start thinking and thinking and you start working. You will find that the rest of the day is just miraculously works very, very well, because you start your day with a noble purpose. And there are different types of publications. When Dr. Palaniswamy told Dr. Ramakrishna about case reports, I'm sure he didn't know how to respond, because I was editor of a journal. And the first thing that we will do in the morning is, when you open access to your editorial manager, there will be about 30 publications or 30 submissions. And the first thing I will do is to reject all the case reports. And a majority of the time, I may not even open it, unless the title will tell me something like EUS guided liver transplantation. So that doesn't happen. But unless something is so fascinating, I never accept case reports. And there are multiple journal associate editors. There's an editor-in-chief, and there were about 3 associate editors for clinical gastroenterology and hepatology. So we started with an impact factor of 3.95 or 4.2, and we moved it to about 7.7 over a period of 4 years. So literally it takes 1 year to increase your impact factor by 1 point, and your impact factor is negatively impacted by case reports. So if you have a lot of case reports, the journals don't like them. Reviews are reasonable, but it should be on very relevant topics, and it should be cited by a lot of papers. So if you write a review and it's cited by many, many people, then I think it moves the impact factor a little high. You can't just write a review because you have nothing else to do, or you want to give your friend a favor. So it has to be an important topic that will be cited. And finally, the cream of the crop is original research. Nothing will replace original research. And if you want to do original research, retrospective studies are low priority, because the data collection is usually bad. What happens is, you may have treated about 120 patients with achalasia over 6 years. You start pulling those charts. Documentation is horribly bad, especially if you are documenting on paper. If you're going to have electronic medical records, it's reasonable. Even in electronic medical records, if you're going to just free text and document, then you're not collecting the data that must be collected. The only way your retrospective data is going to be accurate is having pre-filled text in which you're ticking or you're putting cross marks to say no, then you're collecting good material. Or you must have databases. Like, for example, our pancreatic fluid collection database has 425 or 430 data points. And then you collect data into that. And then you follow those patients over a period of 6 months and so on. And although retrospective, the quality of data is fairly decent. But as I've told you, journals like Gastroenterology and Gut will not look at retrospective papers unless the research cannot be done any other way except by retrospective methods. Prospective data is the way to go. You come with an idea, you design a study, and then you get your IRB approval, and then you collect data prospectively. But the cream of the crop is randomized trials. If you can do a randomized trial, particularly between disciplines, say, for example, you're comparing endoscopy and radiology for pseudosis, or endoscopy and surgery for esophageal early stage cancer, then that's a randomized trial. Well, even if the study has some limitations, all studies have limitations. No study is perfect, but these are the type of studies that will get accepted easily into an endoscopy journal. A little bit more difficult, but even into gastroenterology or gut are even further. So randomized trials must be your desired outcome, but it's not easy to conduct randomized trials. So when you do a study, I think Dr. Ramakrishna is probably more eminently qualified than me to explain this, but the methodology is important. It has to be very clear and concise. Multi-center studies are important. So for example, you can do the best study. For example, recently we published the MISER trial in gastro. We submitted to the New England Journal and JAMA. We got some reviews, but they told us that this experience is unique to one center, to a few doctors who are experts in the field. It is not generally applicable to everybody else around the world. So if you have many centers participating in the trial, it demonstrates commitment. Also, it is a check mark on your credibility, because if somebody is violating the protocol, somebody else is going to point out that this is not the correct way. So it's a good way to do clinical trials, but you need a lot of committed people. Studies with interdisciplinary field has more credibility as well. For example, you're comparing radiology and surgery, radiology and endoscopy. It's very important. These are the papers that will land up in the New England Journal. If you're going to just compare RFA and endoscopic resection, then it is purely endoscopy. I don't think a general practitioner reading the New England Journal cares about this. But if you're going to compare endoscopy and surgery, then I think it's more relevant to the physician and the surgical community, and a journal with that has got a broad-based audience like JAMA or the Annals of Medicine will be more interested in the journal. Before you embark on a clinical trial, always consult a statistician. There's no point in expressing or showing your experience with 25 patients coming out with some percentage points. That usually doesn't help. You have to have a statistician to give you a sample size so that the study is relevant. When you do studies, it's very important to get IRB approval, and you have to register it in clinical trials. If you don't register these days in clinical trials, obviously the study will be rejected right away. It's not even sent for review. It's a tick box. They don't have an IRB number and a clinical trial registration. The study is rejected. It's important to set deadlines. When you say, I'm going to do a study, a classic example is the rule of 3 for esophageal stricture dilation. I still have not identified where the rule of 3 has come from. I always look at the papers and I don't know where the rule of 3 came from. So if you're in Stanley Medical College or Madras Medical College, and if you want to do research, and if you want to do a good quality research, you don't have money, that is the study that's going to change your discipline, because you can randomize to 2 groups where you have the rule of 3, and in another group, you have a 45 French or a 42 French as a deadline, as your endpoint, and you just keep dilating until that point. You have your thoracic surgeon on board so that if there's a complication, they handle it. You got so many patients, you can enroll maybe 2,000 or 3,000 patients between medical colleges. And now you're talking about a gastro or a gut paper, because this will change guidelines. And this is an important paper with very minimal commitment of resources. You have to check the data periodically. You can't just keep on doing it, only to realize at the end, there's a critical data point that was required that you failed to capture. So you have to go on a periodic monthly basis, look at the data, make sure it's being entered properly, and you capture data that is not, that should be there, but erroneously it has been omitted. And you must always have electronic backup. It's not enough to have a bunch of papers, because papers get lost. And then if you have not entered them, you can't make up data. So it's very important at the end of each business day, you go to the computer and you back up all the data so that if hard copy is lost, something else is preserved. We are all clinicians. None of us have time. And this is where you must leverage your connections with pharmaceuticals. You have to get some money. Probably the trust can give you some, can hold that money for research. And if somebody presents a proposal to the GI trust, a group of people should sit together, review the proposal, select the top 3, and it could be 20,000 rupees a month for a research coordinator. And all that they do is to just collect the data and maintain the sanctity of the data for you, making phone calls to patients, running around and maintaining quality control. So when you submit papers, you've got the first page of the manuscript is called the abstract. So when we submit to DDW, I always tell my colleagues, abstract is the front page of the manuscript. It is not a publication. We all cite it, including I cite it in my CVs, but generally it means nothing unless you convert it into your original publication. I generally have a more than 90% to close to 100% conversion. But a majority of doctors across the world have a conversion rate of only 10 to 15%. And the reason is because the abstract will look nice because it's only 300 words, but the study is horribly flawed that they are not able to publish the study, or they don't have the commitment to sit and write a paper. Your abstract should be concise so that if you read it, it will convey the message. It does not have to be detailed. When you write your manuscript should be broken up into 3 thirds. The first third should be a background of the literature. Your second third should address the significance of the problem that is going to be presented in the manuscript. And the last third should be the hypothesis on why you are doing the study. It should give one line on the results and say, this is what we found to address our aim. And this is what makes the study very unique and what implications it has for the future. So with this introduction, you have set the stage for your reviewer to know, because not all reviewers are familiar with everything. They don't read the journals as you think they would. So when you present this data, they will know what is there, what is not available, and what you're trying to address in this manuscript. Your materials and methods, once again, should be concise. It should be organized into your study design, your good study population, the type of patients you are dealing with. You should go into extreme details with how you collected your data. You should describe the laboratory methods if applicable, and as I've told earlier, your statistical analysis. When you go into your results, it cannot be just a monologue of a page and a half. You must have subheadings, and the results should build a story. The results is a very boring part because you're throwing in a lot of numbers and statistics that a lot of doctors don't read it because we are not statisticians. So that's why figures are important. Very simple figures and graphs. And then you should not duplicate the graphs in the paragraph. You should just write 3 lines and say, look at the image, and your results should build a story. And the figure legends and the results, as I've told you, should be complementary and not duplicative. There is something called a supplemental section. So if you think there's anything that is not interesting, but it is important for people to know, for the experts in the field. For example, you're publishing an endoscopy, and a lot of people don't know about POEM and don't care to know about POEM. They just want to know the basics of your research. Then all the details of the methods and what you did should be thrown into the supplemental section, and the results should just give the bare minimum, but it should be able to give all the requisites that will qualify your manuscript for publication. Likewise, your discussion should have the rule of third. The first third should be a synopsis, should just give you the results and say, yeah, this is the study that we did, and this is what we found. The second third is important. Now that you've done your study, you have to put your study in the building block. It's like constructing a building block, and your study should go into the block to make the image full. So you have to say what your work has added to the literature. And then how important this addition of your work to the literature in terms of insights for future research into the field. And in the third part, the final part of the manuscript, you bring them all together like the climax of a movie, where you go and say, this is what I have done, this is what it has added to the literature, and this is how it's going to make our discipline better. And as I've said, there is no research that is perfect. You don't want the reviewer to come and tell you all these things are a problem. You want to be very clear and say, yeah, there's my study has all these problems, and you list them out, and you should tell them why those problems could not be addressed. You can tell the study design can be done only prospectively, not in a randomized design, because it's unethical. Most patients will not be willing to go for early stage cancer to surgery, and therefore, given all the developments in endoscopy, such a study to date in 2021 is impractical, and you address the limitations so that your reviewer is not taking the limitations and rejecting your manuscript. You have to counter that rejection with a counter argument. And then you provide future impact and tell them, these are all the things we have done. This is our experience, for example, and it's very important to to conduct this study in a multi-center fashion to make sure the results can be duplicated and make it applicable for everybody else. And then after you have done everything, how do you choose a journal for the submission? Your work will influence the choice of a journal. For example, if your work is extremely focused on endoscopy, then it has to be, unfortunately, an endoscopic journal. But if it is interdisciplinary, then you're talking about, if you're comparing, say, we did a study recently comparing EUS guided liver biopsy and percutaneous techniques for liver biopsy. So now this could be possibly your submission for hepatology, or you can submit it to gut or someone, and then tell them, because it's interdisciplinary, why one technique is better than the other. The second will be for the don't sell yourself too short. If you really have a case series, you don't want to waste your time submitting case series to gastroenterology, because you're going to find a horrible reviewer like me or an editor who will immediately reject it. You're wasting your time. Just send it to your low priority journal, because it's not going to go anywhere. But if you have even a 10% chance that your paper, if you believe your paper is important, ask some of your peers, ask Dr. Ramakrishna. You can always write to your editor and tell them, listen, I've got this paper, can I submit it? And he'll tell you, listen, this is not worth it, I'm not going to publish it. Or he will tell you, yeah, this is reasonable, send it, I will give it out for a review. What he will not do is to give you a guarantee telling, yeah, you submit, I'm going to publish it for you. That generally never happens. High impact journals generally will prefer only randomized trials and multi-center studies, and you must always have a backup plan so that if it doesn't get accepted, you know what else to do. And there are different types of reviews. If they accept it, it's great. Very rarely will a journal accept it without any questions. Some of them will come with minor revisions. They will say, yeah, it's reasonably a good paper, but you need to fix these problems. This happens only 15% of the time. Most journals will reject and say resubmit. They will tell you it's a good paper, but you got all these problems. We want all the data. We want you to resubmit. We want to fix all these problems. Then you go back. It's a lot of work, but at that point, all those are reject and resubmit. You know it's eventually going to get accepted. If they tell you no way, I'm going to. If they reject the paper, then you don't write to the journal editor. Usually the journal editors don't care. We don't even read your email. You can't say it can't happen to me. I did a great job. My colleagues were all horrible. The world is a horrible place. I've received letters, dear editor, may plague hit your family and your friends. Usually that doesn't happen either. And importantly, don't give up. Always persist, always regroup, and then plan what is there for the next submission. Most importantly, you have to learn from your mistakes. If they point out mistakes at every stage of life, particularly in publications, we can learn. And you don't take it personal. When they give you a horrible review, you take that review, you correct all that you can on that the manuscript, and then you resubmit to a different journal. And you'll be very surprised. Recently, we submitted a paper. It was retrospective study of prospectively collected data on disconnected pancreatic duct syndrome in pancreatic fluid collections. We submitted to GI endoscopy. They rejected the paper, and I was fairly surprised because we write very good papers in this, but they gave a pretty decent review. So we fixed all this review, and we thought the paper felt good. So generally, when you get rejected in GE, you get one step lower. I said, no, we need to submit it to CGH and see what happens. And CGH said they love the paper. They said it's a great paper, it's important, and we're going to publish it. So you always learn from your mistakes so that you can do better the next time. Common mistakes: always do a literature search before you embark on a study. You will be surprised to see a majority of the things on which you want to publish has already been published. So you don't want to waste your time just because you want to publish. And the second thing is, on your wards, your doctors will say, your attending physician might say, well, this is a very nice case, submit it to the journal. Generally, it doesn't work that way. Unless you've got 100 or 200 cases, those type of things don't work. So think well, because you don't want to waste your time. Make sure all that you want to capture is captured in a database. Don't compromise. If you think something is not necessary, still capture it, because once you capture the data, you don't have to use them. But if you don't capture them, you have a problem. If you have decided to go on publications, talk to your statistician. So this is important. If you go to the Madras Statistical Institute, those guys are excellent, but they have no background in medicine at all. They're totally clueless. They can only look through a prism of mathematics and physics and chemistry. They have not consulted for a medical study. So it's important to talk to somebody like your editor. I always talk to my statistician, who's Dr. Bang, and because she's a doctor, she will tell me. And because many of the things that your statistician will tell you is impractical. Second, your statistician, when they write something, you should be able to read and make some sense out of it. So if you go to a pure statistician, they will write things which even you will, as an investigator, even you won't understand. Before you submit your paper, if it is your initial stages in publication, send it to peer review. Give it to all your colleagues and tell them, read this paper. They may not be smart, but they'll come back and tell you, listen, there's a problem here and there's a problem there. And you'll be very surprised. I personally, if I write something on pancreatitis, my go-to person is Pramod Garg. Pramod is very brutal. He will come back and tell you, this is wrong and that is wrong, and you can fix it. I give it to Adarsh Chaudhary. There are very, very good reviewers in India who can review and tell you what can be corrected and what can make your paper a little better. And most important, never make up data. This is very, very important. Never make up data, because we can figure out. There are very, very respected doctors that we all know who make up data and present. And once you lack that credibility, and once your editor finds out, and somebody like Dr. Ramakrishna probably will read an abstract and tell you this is made up. Once you lose your credibility with a journal, it is almost impossible to gain it back. Once gone, it's always gone. It's much better to retract a manuscript if there's a problem, and there's no shame in it. Even to be honest, if you go through PubMed, I have retracted a manuscript myself because we had some, after we published it, there were some issues, and we thought the correct thing to do, the institutional review board told us, so the correct thing to do is to remove it. It's a lot of painful things, but what you want is, you want truth out there in the community. And finally, this is my last slide. It's important to enjoy this process. You can't do it because somebody else is asking you to do it. You have to do it because you enjoy the process. And if you don't enjoy the process, you will not succeed. And most importantly, this is the journal of our society. It is our trust that is running this journal. So you want to maintain quality. You want to give your editor a free hand. You don't want to complain that is rejecting all your paper. If he can move, you're starting with an impact factor of 0. Before this journal goes online, it's going to take a couple of years. Before an index factor is given, it's going to take even longer time. I would rather like to see a journal of 4 pages that is published every 3 months than to see 40 pages that is published every month. And the 4 pages every 3 months, a quarterly journal, will probably have more quality data that will be more relevant to your practice than to have a 40-page journal that comes every month, which is like our newspapers. We just skim the headlines and we just trash it. So with this, I want to wish the journal and the society all success. We are very proud of you, of what you're trying to accomplish. I think, to be very honest with you, I and Rob have something to ask Dr. Palani Swami and all of you. I think we feel pretty lonely. COVID has killed everything. We are dying to have an invitation to come to Chennai and have some dosas and have a real conference in person, seeing everyone. I think we are all a little homesick and conference sick, particularly with our Tamil Nadu audience. So I think you should try to make it happen this year, and we'll be very grateful if it can happen. And thank you so much. And it's an honor to be here this morning. Now, we don't have audio.
I can hear you, V, very well. I heard your entire presentation.
And Dr. Palani is talking, so we can't hear.
Shyam, thank you very much for the excellent lecture on the research and personal development. Definitely, as you suggested, and we'll try to hold the meeting where we can come and enjoy dosas here. And hopefully, because we have started the vaccine program, launch was done yesterday. I had my first shot yesterday. Hopefully, within the next 6 months to 1 year, we should be able to hold a meeting. So there were some, I think, questions in the chat box. I think probably any Karthik, any question there? No? Maybe I'll just hand over to Dr. Ramakrishna to interact with about regarding the publication. You have any questions or any comments?
Thank you, Shah, for that wonderful lecture. I just wish that you could address it to a larger audience, the general Tamil Nadu gastroenterologists, whenever you're here next. You're certainly an inspiration. And as Pandey was saying, you still haven't lost that medical student look. But we just wish that we all had your energy. You certainly made very valid points, and I just hope that we've been recording it so that we can put it out in our website. And Ubal is very, very proactive. He has everything recorded. It's on the website. ISG. No, it's called something else. ISG TNC. And if you go there, you'll find that you're on YouTube and everything's recorded there for posterity. So thank you so much.
Thank you. Sir, Professor Martin, any comments?
Well, thank you for your comments on writing the paper. Writing papers is necessity. The only thing I disagree with you is that you have to enjoy writing papers for them to be good. I have written nearly 200 papers in my life, and I don't think I've enjoyed doing the work, but I've never enjoyed writing the paper. It's a job that has to be done, and you do it because you have to do it.
I recall Professor H.G. Desai. I don't know how many of you remember him. Once he was addressing in Bombay, he said, my generation of senior physicians in all walks of life, gastroenterology, cardiology, whatever I have done a disservice to the succeeding generations for not providing adequate opportunities for them to come up. That's why Shyam Baran brought up in Srivilliputtur has to find recognition in Orlando. And he's got to come back and tell us. If only we had that kind of a stature that your next generation will be one higher than you are. If that can be the attitude to the set of gastroenterologists or physicians ever, then the question of our having to go outside for our talents and merits to be recognized. Anyway, thank you, Shyam. As everybody is saying, he's still looking, they're all saying he looked like a student, but I think he looked like a boyish.
So maybe can I request comment from Dr. Mohan Prasad and Dr. Bala?
KP sir. KP sir.
Yes, Bala, please go ahead.
Yeah, I just need one clarification from our friend Robert Haas. He said that magnetically controlled capsule. Is it available here, available in commercial, Robert Haas?
Magnetically controlled capsule, we don't have commercially here.
So the publication is...
Yes, sir, please go ahead.
Can you hear me? Yeah. So the publication came from China. And so it is not available, I know, in the United States. Whether it's more available in India or not, I don't know. It was just an experimental thing, but it was a Chinese capsule.
VGM, any idea it's available in India?
It's very much available. And if you recall our conference, which happened in Coimbatore, where you were all a part, we organized the Indian Society of Gastroenterology conference. I think in the workshop or the subsequent in 2013, we demonstrated this capsule in Coimbatore itself. It's available. The Korean capsule is available, not the Olympus one is not available, but the Korean one is available.
Magnetic,
you can use the band to control the movement of the capsule in the stomach. So it's very much, we demonstrated live in the workshop.
Is it commercially available here?
Commercially available, sir, in India, yes.
But are the centers, any centers using regularly? Magnetic, are you using
I'm not sure. I'm not sure. People are not using that often.
Is it because it's too expensive?
Not really, sir. Not really, because see, the video capsule endoscopy, the first one was started in 2002 with the given imaging capsule. And so we have all grown with the given imaging capsule. So now we use the Poland 2 and also the SB3. So these cannot be controlled from outside, but nevertheless, those are very popular here and have taken a base. So we have to reinvest for a new system to get this, endoscopy going. So, many of us did not indulge in investing further and starting something with a newer capsule.
Any final comment from you, Dr. Prasad?
Yeah, I mean, it's a wonderful day, sir. My salutations to all my teachers. I'm seeing Professor Martin, and Professor Krishnan is also my teacher in a way, because he keeps advising me all the time. So, and Professor KR is here, and yourself and Dr. Ramakrishna, and have stalwarts. And my hearty congratulations to the Tamil Nadu ISG, especially the trust. And as this is completely captained and piloted by Bala and yourself, and you have done phenomenal work, which I don't think any state in India can ever boast of. So our Tamil Nadu Gastroenterology Foundation is something unique and phenomenal. So, and with the addition of the journal, it's really fabulous. And even though we would strive to, achieve what Shyam has clearly expressed, how an article should be, but as Professor Ramakrishna put it, probably it's an inspiration to our youngsters also to write. And as they start writing and their articles get published and more reviewership and then comments, I'm sure they can fine tune and probably get into the groove of publishing fantastic data like Rob and Shyam do for the whole globe. I think the days are not far away. I think our youngsters can start getting publications in our journal and can definitely progress further. So my hearty congratulations. Thanks once again for this opportunity.
Thank you, Prasad. I think all seniors we've been talking. I thought I would like to introduce two of our registrars. One, this is Dr. Karthik, our senior registrar from, he's a final year DNB student from Apollo. And this is Dr. Rohan from SIMS. I would like them to say a few words about this journal and about the whole meeting.
Thank you, sir. First of all, I'd like to thank Dr. Robert and Dr. Shyam for giving these wonderful talks. I had the opportunity of meeting Dr. Shyam when he was here in Chennai recently. And I would just like him to, say that if probably we would cater to a larger audience, these talks are really inspirational, sir. And we just saw, actually, when Dr. Shyam was here, he spoke to our registrars in Apollo for close to an hour, and we saw two different sides to him, something that Dr. Robert mentioned as to how he has a childish side to him, how his consultant side, and we also saw as to how aggressive he is when it comes to publications. And I think that's a leaf we would like to take out of your book, sir. It's something that we would really like to adapt. I want to thank Dr. KRP, Dr. BSR sir, Dr. Krishnan sir, and Dr. Matan sir over here. They have been pushing us to publish data, and I would like to thank Dr. Ubal sir as well, who's been giving us plenty of opportunities right from the Tamil Nadu ISG chapter as well as from the trust. We are getting opportunities to publish our data from whatever we have accumulated in Chennai, and Rohan is part of it. We will be presenting the final analysis of the IBD study very soon. When the journal was announced around 2 months back, I had sent 3 case reports to Dr. B.S. Ramakrishna sir. He, in fact, just like how you said, Shyam sir, in fact, he sent changes the very same night at 1 o'clock. And actually, till date, he has been chasing me, and I promise that I will send it in the coming week with corrections. We are writing review articles. The thesis subject, our exam date hasn't been announced yet, and we are writing review articles on what we have been studying as a thesis subject, mine being impedance pH monitoring for the journal. And we will be looking forward to publishing even randomized control trials in this given a chance very soon, sir. Thank you so much for this opportunity. Thank you so much, sir. I'd like to hand over the mic to Rohan. Thank you.
So I just concur with what Karthik just said. It's an honor to be here at this prestigious event for the journal launch. And it's an event where my guide, my sir is here along with his guide. So it's like a 3-generation thing. So this is a unique event which I've been a part of. And yeah, it's kind of very encouraging that sir keeps encouraging us about documentation in our day-to-day practice, despite the busy OPD, everything. I see sir document everything individually on an everyday basis, like how he does, and that's quite inspirational. And we try to draw inspiration from that and do practice that in our life. And I think this is just a start, and we would like to take it further from here, even after we finish our residency in our respective hospitals. And this journal is a unique opportunity for postgraduates to present their data. And I mean, there's no better person than sir who can give us advice and guidance on how to write articles. And I'm very honored to be here. Thank you.
I would like to thank both Karthik and Rohan for their comments. And now I think it's time for a word of thanks by Dr. Wall.
Thank you all. I think it's a wonderful evening, and a special thanks to Professor Robert Haas and Shyam Varadarajulu for their wonderful talk and the short notice they accepted our invitation. It's a great pleasure to have with us. As Rob said, I think we may trouble you, Shyam. Maybe we can include you in our editorial board soon, and we will involve you in all our journal works from further on. And a special thanks to Professor Mathan and Krishnan sir for accepting and releasing the first issue. Hope that we go higher from this side. And special thanks to our Professor B.S. Ramakrishna. Without him, I think this is never happened in a real time. And a special thanks to Professor B.S. Ramakrishna. And thanks to our trust members, Dr. Raghuram and Muhammad Ali and Ratnaswamy and Prem Kumar, to come here and share the evening with us. And a special thanks to Professor K.R. Palaniswamy, because without him, I think this function will not happen. Because when we have this COVID time and among the pandemic, we are looking for a place to have a meeting where everywhere there's a corona in all star hotels. We finally choose this venue, and a special thanks to Professor KRP and also to A.C. Muttaya, the industrialist chairman. And he gave this place and also gave the food and everything for as a free of cost. This is a special thanks to A.C. Muttaya, the chairman of the industrialist. And thanks to our audiovisual guys and Bala of Forts, who gave us a platform to have the functioners. And finally, and the last but not the least, Dr. V. Balasubramaniam, who is the main pillar for the trust as well as Tamil Nadu Gastroenterology. Without him, I think nothing moves in this part of the world. And special thanks to Professor V. Bala, and for always encouraging and supporting the trust as well as society. Thank you all, and we have our dinner now.
Ubal, how about our dinner? Are you going to send us electronic?
I think it's dinner time here. I don't know for Dr. Shyam and Dr. Haas.
Breakfast time.
We can have dosa.
Request or your
Yes, please send us some dosa.
Dosa. Okay, maybe next time. Yes, so we're looking forward to see you here to give you dosa. Thank you very much. Thank you, Shyam. Thanks,
you.
Dr. Haas. Thank you.
Bye all. Thank
Dr.
you.
Prasad, thank you. Dr. Bala.
Thank you, sir. Thank you very much. Shyam, Robert, sir, thank you very much.
Bye, Bala.
Shyam, in your slide, you wanted to send plague to the editor's house. Today you sent corona, not the plague, so you can correct it. And probably the mutant corona.
Okay,
Bye.
bye.
Bye. Bye-bye.